I'm the chair at Brown in Providence, Rhode Island. And I'm taking a slightly different tack. This is going to be about advocacy through professional organizations. But I think this is hopefully worthwhile because as physicians, many of us already have relationships with professional organizations, and it's often a place that we first think of going. My disclosures, I'm a dues-paying member of ASAP and SAEM. I've served as a volunteer currently on the ASAP Quality Committee and the Registry Committee. I've been on multiple ASAP committees and task forces, but I've never been an elected official of ASAP. I have grant funding from Medicare that goes through a subcontract with ASAP for the Equal Quality Collaborative, and I'm a paid consultant to the Emergency Medicine Foundation Health Policy Fellowship, although that's ending this year, so I'm not sure if I'm technically paid by them anymore. So a couple objectives. We're going to review the structure of professional organizations because I think it's really important to know how professional organizations work if you're going to effectively advocate with them. Many of us get pulled or introduced to medical professional societies in medical school or at a later point, and we actually never, unless you get quite active, never really understand how they completely work. Understand one perspective on how to effectively advocate with professional societies, and then review several cases of advocacy. So what is professionalism? It's a social process by which a trade or occupation transforms itself, and people have described this. The woodcutting on the top is from the 1500s. It's a guild. It's the hatters. The picture below it is Rembrandt. And it is the drapers, who I guess probably made drapes. Medicine comes from the history of being a guild. And what professionalism includes establishing qualifications, having at least one professional society that maintains best practices and oversees these, some sort of demarcation like professional certification, and then usually a closure of the occupation to people who don't meet that demarcation. And so professional societies are one aspect of professionalism. And so more Rembrandt. The one on the top is the drapers. The one in the bottom is a famous Rembrandt that most people have probably seen, and it's, I forget the name of the picture. It's the surgery of Dr. Sinak or something like that. But it's really hard to tell the drapers from the surgeons. We would be very insulted nowadays. And there have been a bunch of different definitions of professional societies. They're listed here, but they show a couple different aspects. One is a group of learned people that are entrusted to maintain control and oversight of a legitimate practice of that occupation. So you think about medicine, law, accounting, things like that. A body acting to safeguard the public interest. And that's what professionalism is, to make sure that if you're a lawyer, you're not someone who just says they're a lawyer. You actually know what you're doing and you have ethics. And then to represent the interest of the professional practitioners, really as a trade group. Features of professional societies include that they are membership organizations and their members are part of the profession. They have some type of democratic representation. And then they have a multi-part mission. It's not always the same, but it generally includes a mission to the professional members, a mission to patients, and a mission to society. So there are lots and lots of medical specialty societies, and I just gave one, how I think about classifying them. There are the general medical societies, so the AMA. The AOA we often don't think about enough. Are there any osteopaths in the room? Great. The new president of the AOA is Kevin Clower, a very well-known emergency physician. I've worked with him. He's going to be great for the AOA and for really medicine. Geographic medical societies. All states have medical societies. Many specialty societies have state medical societies. There may be county medical societies where you are. Specialty societies. So American College of Emergency Physicians, AAEM, are specialty societies. Population-focused societies. The National Medical Association is an organization for African American physicians and the patients they serve. And you can imagine this popped up, and it says since 1895, because once a few African Americans were allowed to actually become physicians, they were often not allowed into professional societies or didn't feel welcomed. Interest-focused societies. SAEM to me is an interest-focused society. It's focused on academic emergency medicine. Physicians for Human Rights is a different interest-focused society. And those will attract physicians that have, and maybe other professionals that have those interests. What's slightly different at the bottom is a specialty board. ABEM is a specialty board, which is different than a professional membership society, and I'll go into that in a little bit more detail. It's important to not forget the non-physician professional societies, particularly when you're doing advocacy, because there are many more of them. They bring a great perspective on most of the issues that people in this room are going to want to advocate. Nurses, other allied health professionals are very good advocates, and they may have the same they often have a similar structure with specialty organizations or local organizations. This is one of the key concepts, I think, about understanding working with specialty societies, that the multi-part mission of professionalism has some things that are sort of at odds. You talk to people in a medical professional society, and they say, we are about the professionals, we're about the patients, and we're about protecting public health or medicine for the public. And there are areas in the middle where those three all overlap. I moved the bottom two circles together because I think there's the most overlap between patient interest and public interest. But there are clearly things where our professional interest as a trade group is not necessarily aligned directly with what a patient group or what a societal group. And the two examples I gave across these are, think about regulations around sepsis. Most physicians want autonomy. They do not want regulations about how to practice medicine. Most patients would want increased regulatory burden, whether it's standards of best practice or medical liability type ways to have enforcement after the fact. The public interest would be in some balance between a fair regulatory burden that is fair for the professional and for the population of patients, and may actually subjugate one individual patient's interest. You can think about reimbursement. It's pretty straightforward. Most physicians would like to be paid more for a service. Most patients would want their payment to be less. And the societal interest is to think about reducing the total cost, at least to the point where you're still getting high quality and you're getting value. Every specialty society is different, but there's a general structure, which is there's a membership organization, dues-paying members. Often specialty societies will talk about how they represent the whole group of professionals, and they may act in that manner, but ultimately it's dues-paying members who have a chance to vote and participate. They have groups for those members, things like sections or academies, which are ways for members to self-organize and get work done. If it's a large organization, they may have a representative body that makes the decision, a council. The American Medical Association has a council, ASAP has a council. Smaller groups will not have a council because there just may not be a need to. And then they generally will have a board of directors. The board of directors is often largely volunteer, and so they will have volunteer members and dedicated staff who will carry out the work of the organization, and that's in committees and task forces. And that reports back to the board of directors as opposed to a section or academy, which really is made up directly of the members. So what impact can professional societies have? They can influence their members through guidelines, registries, campaigns. So you can influence the way people practice medicine. They can have a public influence. We know the white coat, the reputation of physicians can carry weight. And so if you have a whole group of physicians, pediatricians, women's health doctors talking about an issue, it may carry significant weight. They can have political influence. They can make policy statements. They can lobby to have influence on legislation and in particular regulation, which is most of what affects us. And then they can do direct lobbying, either direct lobbying with members and staff or through political action committees. So I'm going to quickly run through the emergency medicine professional societies. I'm going to mention a couple of things about them. I'm not claiming to be the complete expert, but I would mention these because it's important when you think about how you might advocate with them. The American College of Emergency Physicians was founded in 1968. In 2000, they changed membership requirements to include board certification or residency training to become an active or full voting membership. They, on their website, claim to represent more than 38,000 emergency physicians. I don't know if that's the dues-paying members or if that's all the people who are emergency physicians, but their dues-paying membership is over 30,000. It's a very large number. They have chapters in every state and territory. They have lots of committees that are set to execute the strategic objectives that the board comes up with. They have a council that's elected by the sections and the regional areas, and the council meets once a year and comes up with items that the board has to then follow up on. And this is directly from their website, sort of what they promote, and you can see here a number of the different tools that they have as a specialty society. They fund EM research. They do legislative and regulatory advocacy efforts. What I would highlight, I think, in the emergency medicine space is that ASAP is the largest and wealthiest organization and has the most contacts in the federal government space. And so they tend to be the organization that federal agencies go to when they're looking for input, and they have direct contacts with more lawmakers than, particularly on the practice of medicine, than most of the other medicine organizations. AAEM is a parallel professional society for emergency medicine. It was established in 1993, and its focus is around fair and equitable practice with a particular interest in democratic and individual practice as a response to concerns about corporate management and large group management and the role that those organizations have within ASAP. That could be a whole discussion. I'm not going to get into it, just to say that there is a separate organization. They do not list on the website the number of members that they have, and this is mostly from their website about what their values are. They also have chapters, they also have committees, and they do much of the same types of work that ASAP does, not at the same scope because of the size, and they have more of this focus on democratic practice and trying to address concerns that physicians have with corporate management groups and other practice management groups have. They also publish a journal. SAEM is different. SAEM has a focus on academics, research, education, scholarship, and has a membership of, I think, about 6,000 physicians. It has academies, it has committees, it has a board of directors that is elected by the members. There's no intermediate. It tends not to get involved in regulatory or law issues around the practice of medicine, except where it comes into areas around education and training, for example, things that may have to do with GME. It is very active in advocacy around research funding, for example, with the NIH and the NIH budget, NHRQ, and things like that. ABEM is our specialty society, is our medical specialty board. It was established in 1980. It's not membership-based. The board members are chosen by a process through the board. There is no election. People do not run, or there's no general election. It's the member board for emergency medicine on the American Board of Medical Specialties, and it really holds that space of having the certifying authority for the specialty. Whereas both ASAP and AAM offer fellowship status, that does not carry the same weight as being board certified, when you go to get hospital credentialing, for example. It's not involved in advocacy or guideline development and stays out of that. So why advocate through and with professional societies? Positives are access to a large group of physicians, the ability to develop influential standards and policy statements that may be used in medicine and outside. So publishing a position paper with a professional society can often get picked up by industry, by guideline setters. Often specialty societies are either nominating for or ask for representatives to serve on either government or non-governmental organization committees, which is another form of advocacy. There's an opportunity for legislative and regulatory advocacy. Professional societies may have active lobbying efforts either around the clock or once or twice a year, and it's a way to get a bunch of physicians together to do that. But why not advocate with professional societies? I think many individuals in medical school who sort of want to get actively involved immediately are pulled into professional societies, and there are some things you can do, but it's important to think about how it may not be the most effective method for advocacy. There may be conflict with parts of the mission. So if the topic that you're doing is a completely public interest topic, is the specialty society going to be ultimately aligned with what's in the best interest of that organization? And it may not mean that you don't want to get them involved at some point, but is it the right group to start with? Is it at odds with key constituents? So for medical groups, the #1 issue for almost all professional organizations is reimbursement for physicians. And so they know who their constituency is at the state, national, local level around this. And if, because of political affiliations or other things, you are working on an issue that is completely at odds with these people, it may not be the best partner organization. Is it the best partner or venue? Does the specialty society have any role in the issue? You could organize there, but ultimately they may not have a seat at the table, and their voice may not be particularly important. And if you want direct patient or community engagement, being involved with physicians is generally not the best way, because we tend to be pretty removed. So working on those community organizations is a great way to start. So I'm going to run through a framework for how I think about successful advocacy with professional organizations, having done this on a number of different efforts. I'm sure there are other frameworks, and I have this as a series of questions. Is the issue core, related, or unrelated to the organization's mission? So if it's core, it should be in their strategic priorities. All of these organizations have a strategic priorities. And if it's related, it's topical to their mission, but it may not be in the strategic priorities. If it's unrelated, it's not germane to their mission, and it's probably not the right fit. When should I aim to wrap up? Okay. Second, what do you hope to gain from advocating through the specialty society? You want to set specific goals. For example, drafting a policy statement on medical marijuana is a reasonable goal for a specialty society. There are other goals that a specialty society couldn't get through. Is there a clear home for the issue in the organization? Is there a committee, a task force, a section where this issue will fit? Or is the organization going to be willing to create that if you have enough people who can do that? Are there allies in the organization that share your goals and will help you advocate? What roles do they play? Are they in committees? Are they on the board of directors? Are they active people in the council? And then who else do you need to convince and influence to get what you want done? And so thinking about the structure of the organization and then how to do these things for your goal is very important with professional organizations. So I'm going to tell a brief case study about choosing wisely. Who's heard about the Choosing Wisely campaign? I was quite involved in getting emergency medicine to be involved, and at the time it was not as thought out as it looks in the rearview mirror, but I think it tells a little story about working with professional organizations. I've had a long-standing interest in the cost of emergency care, what we can do to address issues of cost. And it's been a persistent theme in medicine and will continue to be a persistent theme in medicine. In 2008, to try to counter some of the public narratives, ASAP put together a campaign called the 2% campaign. I'm blanking on the word right now, but their statement was that emergency medicine only costs 2 cents on the US healthcare dollar. That was definitely a gross oversimplification, but it didn't solve the debate. And there's a great article that came out in 2010 as healthcare reform was being discussed by Howard Brody, who's a bioethicist. If you haven't read it, I would completely recommend reading it. And he basically pointed out that in the whole discussion around healthcare reform, every other constituency with money at stake had come to the table and said, we're willing to go into healthcare reform and we'll give up something. Pharma said, we know we're going to get more patients, we will give up a little bit on pricing. The health insurance company said, we'll give up something on the medical loss ratio. You can debate about how genuine that was, because they may have been making a cost-benefit assumption, but he points out that the only group that did not come to the table and offer to give up anything was physicians. We did not offer to give up anything. All we said is, we want more patients. We will do the same thing, and now more patients will be insured. And his point was that physicians have an ethical obligation around cost effectiveness and affordability, and that each specialty society should come up with a top 5 lists of procedures or diagnostic tests that we make money off of, where we know there's evidence of overuse, and then we should come up with the list and manage that overuse in the interest of society. And this was really the impetus that ultimately led to the Choosing Wisely campaign. A bunch of internists, general internists, did a research project and came up with a top 5 list for general internal medicine. And I'm sure other people thought about doing this once we read the article. So in 2012, I was representing ASAP at an American Medical Association meeting that was their national collaborative around quality improvement. And I served as a representative for several years. And it's one of these national meetings in DC, and we did some work groups and stuff. And then the leadership of the American Board of Internal Medicine got up and announced that in a month they were going to kick off Choosing Wisely. And 9 societies had joined. And emergency medicine was not, they didn't say we weren't one of them, but they listed the ones there, and we weren't one of them. And so I'm sitting on my computer, and I start emailing the people, because I was on the quality committee, and I said, why didn't we join? And it was an interesting, because I was surprised, because we've been having talks about cost effectiveness. And what I learned was that the ABEM letter went to the president of ASAP. The president of ASAP gets all sorts of requests, and they basically turf them to the right committee. And he turfed this to the Medical Legal Committee, who said, doesn't help us, may increase risk, don't join. And he turfed it to the Clinical Policies Committee. And the ASAP Clinical Policies Committee has a very set way they do work, and they don't really do stuff outside of that. And they said, this doesn't fit in the work we're doing, let's not join. And so no one looked at it really with an overall picture, and so the option was no thanks. I was concerned, and a number of other people who were working on this, that this was a missed opportunity, both to be leaders in cost effectiveness and quality, and that we would eventually look like we were contributing to the problem. And so I worked with other people, and we really made our goal to get ASAP to join the Choosing Wisely campaign. And we knew the barrier was approval of the board of directors, because that's who needed to approve to join something like this. That's the way that ASAP at least works, and most specialty societies, to join a major national effort, the board needs to sign off on it. And so we needed to answer 3 questions. First was, what was the benefit to the college? Second, what will expose us to more medical legal risk? And third, will insurers stop reimbursing for items listed on the Choosing Wisely list? These were the things that came up in discussions with members of the board. So our approach was to try to gain more allies on the board, and we tried to do 3 things. One was develop more sort of background publications, research, and evidence that would support this. As an academician, I thought about doing research. We worked with someone who put a resolution together on the council that said that ASAP should join Choosing Wisely. And then a number of us did personal advocacy with ASAP leaders to try to counter number 2 and 3, which really seemed like myths as opposed to real reasons not to join this campaign. So we published, we did a local project and published a paper which was the top 5 list for emergency medicine. We really wanted ASAP to do this, but since they weren't going to do it, we did it locally first to say this can be done. We had this council resolution that got modified from joining Choosing Wisely into developing a task force to look at cost-effective care. And since I had a good relationship in the organization, even though sometimes I pushed them, I was asked to be one of the co-chairs of that task force. We did a survey of the entire membership, got a bunch of pros and cons, and went back to the board, and they decided to join Choosing Wisely. And then the next step is they created a task force to come up with the recommendations. And I got to be a co-chair of that also. I could talk more about it. The interesting piece about that, and this is why advocacy within an organization can be important, is that there were clearly people who wanted to choose the lowest hanging fruit possible, things that would have no impact on our practice, so we could say we had joined. We ultimately put out lists which at the time I think really were meaningful things. 5 of the 10 things were radiology tests, which are a significant contribution of us to the overall medical cost. What we didn't put on there, which was very highly rated, was reducing low-risk chest pain admissions. We know there's a lot of cost associated with that, but that was a little too far in the medical legal area. So on the website, there are some case studies if people want to look at them and think through how they might do them. We don't have time to discuss them. But thanks for your attention and the chance to speak. And I would just point out that medical professional societies are complex organizations, and if you're going to engage them around advocacy, think about their structure of a membership organization, the fact that they've got these multi-part missions, and how you can be successful in advocating with them in light of that. Thanks. I don't know, is there time for a question? Any? Okay. Any questions or comments about professional society advocacy? The last comment I will make is there are plenty of critiques I have about ASAP as an example, and I think this is true of lots of organizations, of professional societies. But what I will say is it is a very democratic organization. The things that they do reflect the council's will, which reflects the will of the people who are involved with the organization. And my general comment would be, if you want to do professional society advocacy, it's really very possible to change the will of the organization by getting a bunch of like-minded people involved, because overall there aren't that many people who are involved. You have the mic.
In your experience, what is sort of the best way to make inroads into organizations like this? I mean, is it just cold calling and cold emailing, or is it working through networks to talk to someone who takes you seriously? What's the best approach?
So I would suggest that joining a committee, joining an interest group that fits your interest is a good way, and meet people. And then at conferences and things, speak to people who are on the board or who are on the council and ask them about issues. The people who tend to run for those positions are generally the type of people who are like student body president. I'm not that type of person, but those people actually want to be liked. They want people, and so if you go up to them and ask them about something, most of them actually want, they want your vote, they'll listen to you. Sorry, you were going to say something?
Oh, I was just going to ask about if you've decided not to join certain organizations, and kind of that balance of being within, I'm thinking less so within EM and more like AMA. If you disagree with their policies, do you join and fight from within, or do you say not?
It's an existential question, and I think it's a great question people can debate about. What I would say is I would encourage anyone who's interested in health professionalism advocacy to choose some large organization and be on the inside, because and I'll point out what AAEM and ASAP. ASAP is the larger, more powerful organization. AAEM is smaller. I think there are strong points the AAM makes, but in terms of the effectiveness of the organization, a lot of it has to do with how many people are inside and the resources they have. And so I would not drop out of everything. It doesn't mean you need to be a member of everything.
I just want to make a point to your question about how to get involved. Another avenue is that the council and most of the policy generating apparatus at ASAP is state-driven. The state chapters carry all the power in the council. And so getting involved at the state level is really a simple matter. If you're anywhere near to your state capital or to where the state board has their meetings, the state board meetings are usually open to membership. So if you're a member of ASAP, you're a member of your state chapter, and you can go to the state chapter meetings, board meetings, and you can start to learn who people are and how to get involved. And it's a great way to influence.
And you can bring up a topic you're interested in, say, I think we should work on this. How do we do that?